just going to kind of start at the front of the chapter and point out things that we've already talked about as we go through. So if you want to highlight or mark them in there where you can go back and pick up the reading on that. We've already talked about a lot of it. So I know the other day we talked about the makeup of blood, what blood does. On 401, we've got transportation, regulation, protection. We already noted there's 60,000 miles of vessels that serve throughout the body. Then the second circulatory systems on 402 and the lymphatic system, we discussed that. And then we broke blood down into composition, where we had plasma and formed elements, and that's talked about on the next couple pages. When we looked at plasma, which had basically 90% water, and it had erythrocytes, that was a formed element, sorry. In the formed elements, we had erythrocytes, white blood cells, and platelets. They start talking about those on 404. And we decided erythrocytes were the most abundant, obviously. White blood cells are second. We talked about different groups of white blood cells. We listed several. And then in the clinical application, they talk about three different kinds of anemia. So I would pay a little bit of attention to that. Most common type of iron is iron deficiency anemia caused by deficiency of iron, obviously, which is a very common thing, and it's really easy to fix. That one is. And then in pernicious anemia, there's an inadequate amount of vitamin B12, which is also another one that's easy to fix. If somebody's anemic, most doctors will prescribe iron and give them a shot of B12. That's the first two things they'll do, and usually that fixes it. Without even getting technical with exactly what kind it is, that'll fix most anemias. Then the last one's aplastic anemia, and something here is destroying parts of the bone marrow. So anemia due to destruction of bone marrow, which may be caused by chemicals and or radiation. So this would be an easy diagnosis as well for a lot of cases, because it's somebody taking radiation for cancer. And so this is not an uncommon thing at all, because those people occasionally they have to give them a couple of pints of blood to keep them up and going, and because their bone marrow's been destroyed. Yep.
What if a person's been diagnosed with aplastic anemia and they haven't had any chemical exposure or any radiation exposure?
Well,
is that possible?
Yeah, it is possible that they're going to have to dig around and find out what's killing that bone marrow. So, and sometimes we're exposed to things and we don't know. That's a much tougher diagnosis for sure. Now, as far as knowing what it is, it's not as tough as what caused it. That's what we need to stop. So, then they go through the white blood cells, the granular, agranular, and we talked about neutrophils, lymphocytes, and macrophages, and eosinophils, and basophils. Those are all listed there as well. Some other clinical application terms: polycythemia, leukocytosis, leukemia, leukopenia. I would be familiar with some of those terms as well. We went through hematopoiesis the other day, which included erythropoiesis and leukopoiesis, which is making red blood cells and making white blood cells. Pretty much covered that. ABO system starts on 408, and I think we hammered that. I want to talk a little bit more about that, because I don't think I covered this aspect in this class, but I did the other one. And how I did that, I don't know, because usually I can't get squat done in the other one. That's a talking bunch of people. I'm glad to have questions, but boy, we chase a lot of rabbits. We kill a ton of rabbits in that class, Ted. But let's just take A and B. We know we can't give A to B and we can't give B to A, right? So the reason is incompatibility will cause agglutination. Those are the obvious reasons. But A is an antigen to B, and B has antibodies against A. Now, I'm pretty darn sure I have a test question worded like this. A is an antigen to B. An antigen is anything that causes an immune response. So that's like throwing something foreign at you, okay? A is an antigen to B, and B has antibodies against A. We could flip-flop that and say B is an antigen to A, and A has antibodies against B, because they don't like each other when they're separated. Yet there is a blood type out there that is codominant, AB. Okay? Does that kind of make sense? I didn't cover that the other day because of the test question. I want to make sure I got it covered today. We've got a rule on the RH factor. You can give a negative to a positive. You cannot give a positive to a negative. There's erythroblastosis fetalis listed on 410. And then we get into blood clotting, which we went through the thromboplastin, prothrombin, thrombin, fibrinogen, fibrin. We've got a clot. And we decided that a wound created by a dull instrument will clot faster than a wound created by a sharp instrument. Aspirin inhibits clots, right? It inhibits clotting by reducing the stickiness of the blood. They've got a clinical application there that even goes further in depth than that, but I think we've got the gist of it. So it takes us all the way over to 413, dissolution of clots, and we listed in our notes, we had kallikrein, which we've learned to mimic kallikreins. We can give somebody a shot of kallikrein that starts a natural reaction to break down clots. It'll take plasminogen, turn it into plasmin, which starts dissolution of clots. Other things we can throw in there, of course, is heparin, Coumadin drugs. There's a variety of those that are available out there today that prevent clotting or would dissolve clots. Now, a little bit of difference in the Coumadin drugs, because of what they have to do is get out there and fight vitamin K for its position in the clotting mechanism. It may take them a week or so to really be effective. And those are the most common drugs given to stroke patients. Unfortunately, by the time they start working, sometimes they'll have a second or a third stroke in that week's time frame. So they have to be extremely careful monitoring this process to hopefully to prevent that. But once they kick in, it really does reduce a lot of stroke activity. Then we get into the structure of the heart, and that's kind of where we picked up on Monday. The structure of the heart, your heart's supposedly about the size of your fist. And we know the left side is systemic, the right side is pulmonary. Went over the heart in lab yesterday, so we kind of have a gist of circulation. We know all the valve's purpose is to reduce blood flow. And then your lab asks a correlation with heart sounds to what was it? What was it? The Q, yeah, the different waves. That's what was, and there, we're going to cover that here in just a second. The heart sounds love dub. I like the way some books do this. They have love, and then they have dub in all capitals. Which one would you estimate to be the loudest sound? It would make sense if they capitalize and emphasize something. It's like on one of my biology tests, I have what does the prefix of the term vaccine mean, the prefix vaxa? Well, it means cow. So I have all these different answers down through there, but cow is spelled like that, all in capital letters. So if you miss it, you're not very sharp. I capitalized it and bold printed it, so hopefully you wouldn't miss it. So that's what they're doing with this. They don't necessarily bold print it, but they're telling you which sound is loudest. Now, what causes these sounds? Love's caused by the closing of the atrioventricular valves. Those are interior to the heart. That's your tricuspid and bicuspid. Number one, they don't deal with a lot of pressure, so that sound wouldn't be loud. Number two, they're muffled by the muscle of the heart. So there's two reasons why that's not going to be real loud. The dup sound is caused by the closing of the semilunar valves. And I think it's one in particular that we hear a lot of, and that's the aortic semilunar valve, because that's most of your pressure. It's superficial. It's not necessarily interior to the heart. It's on the outer edge of the heart, and it's dealing with the most pressure of any of those valves. The pulmonary semilunar valve is pretty much hidden in the heart as well, so I'm not sure we're picking up that sound much at all. But, and there's not much pressure there. but we're sure picking up the aortic simulator valve for that second sound, much louder. Heart murmurs on 416. Murmurs are typically due to defective valves. Now, what could cause these defective valves? You could be born with them, or different forms of disease or infections can cause these defective valves. They list one, rheumatic endocarditis, associated with rheumatic fever, where valves are damaged by antibodies made in response to infection from strep bacteria. In other words, if you have strep throat and you don't go get it taken care of soon enough, your body builds antibodies against strep bacteria that actually attacks the valves of your heart. And by doing so, you'll have a permanent valve defect, and it will mess your valves up for a long, long time till you get them fixed or die, one or the other.
Do those go away, heart murmurs?
Heart murmurs typically do not go away.
'Cause I had one, I mean, they would find it every time until I was about 12, and they would find it since.
Hadn't found it since. I would suspect that it's still there. They found a heart murmur on my mom, and I say they, one particular doctor, and he was just a family physician, found a heart murmur on her and sent her to a cardiologist, and he finally found it, and he said, if that's the best you got, we're not gonna worry about that. Because I don't know how many doctors listened to her heart for years and never found anything. So the minuteness of it plays a huge role. I mean, there's people who live their whole life with a slight heart murmur, and it never gets any worse, never gets any better, but it really doesn't cause any major problems. It might later in life, but it'd have to be 80 plus later in life. You know, my grandfather had valve defect, and I don't know if he had it his whole life or not, because, you know, that group of people just didn't go to the doctor. And I bet he didn't see the doctor from age 0 to age 60. I think he saw the doctor less than 5 times. So, and beyond 60, he had some little skin cancers and things that my dad would make him go and get cut off or burned off and things like that. And just out of the blue one time, they found this heart defect. And what was happening to him is anytime he would exert himself physically, he'd just pass out. Then he'd come to and be all right for a while, and he'd just pass out. Well, found the heart defect, and at that time, he was about 80. And doctor said, yeah, I think you're decent enough health. I think you can survive surgery just fine. We can go in and fix that valve. And my grandpa looked at him and said, you ain't cutting on me. He said, I lived a long life. I'll be just fine. And the doctor said, okay, if that's your choice, this is the way your life will be the next 3 years. And I mean, he told him what was going to happen in sequence in the next 3 years. And that's exactly to the T what happened in the next 3 years. And he died in his sleep just like the doctor told he would. So he'd be sitting there in his chair talking to somebody, and look over there, he'd be out. He'd just be asleep. And then we're still talking, and directly he'll wake up and answer a question we'd ask each other. You know, he was conscious and subconscious the whole time. But if he got up fast, he'd all just pass out. But that's the way he wanted to go. So I really can't blame him at 80-something years old to go under the knife and try to survive. A lot of times you end up bedridden and you don't ever recover. Your heart gets better, but everything else starts going downhill at that age. And
well, you die of an infection. Get your heart fixed.
Get your heart fixed, and a blood clot goes to your brain, kills you or something, you know. And then you got this massive bill that he surely couldn't afford to pay, and Grandma couldn't have paid it. So that just left Grandma in dire straits. Probably gave her a stroke sooner than she had one. This is the grandma that decided to only take high blood pressure medicine when she felt high blood pressure coming on. Yeah, she had a couple too many strokes, but I tell you, those are some classic age group of people that would give you the shirt off their back with a nickel out of their purse if they had one. If they didn't, they'd try to find you one. But that's just the way they were raised and the way they were. Mitral stenosis is one they're talking about here. Mitral valve becomes thickened and calcified, and that it was a mitral valve problem that my grandfather had. And you know, most heart problems in general are left side problems, whether it be enlargement on the left side, whether it be a valve on the left side. You know, even pulmonary edema is usually caused by left side problems, not getting the job done and backing blood up. The left side has the most stress on it. It has the most work ahead of it. Then there's some septal defects that they list, and that is, of course, we know where the septum is from lab this week, and that's where there's a hole in the septum, and so when pressure builds in the left side of the heart, we're supposed to shoot out through the aorta. We force some back to the right side because there's less pressure over here, and that causes pulmonary edema because that backs up into the lungs as well. Those are typically fairly easy to fix if you consider heart surgery easy. I mean, it's once they get in there, they can fix it, but the recovery is always the worst part of that. Clinical application, they're talking about a little bit of resistance here and fetal circulation. I don't have any fetal questions on the test. I think Miss Afzali covers that probably in anatomy that she does. I know Mr. Hebert always covered the fetal end of it, so I really didn't ever cover it much, but they have a nice clinical application over it. On 418, this is probably pretty close to where we kind of left off the other day, where we had the atriums contracting at the same time because the SA node was sending a message out at 70 beats a minute. And then 0.2 of a second later, the ventricles would contract because the SA would send a message to the AV. AV would send it down through the bundle to the Purkinje fibers, and then the ventricles would contract, and then they both relax at the same time. So out of 0.8 seconds per contraction, 0.5 is in relaxation and 0.3 is in contraction. And that's kind of what they're telling you here. Now they will say as well that the ventricles are typically 80% filled by the time the atria contract. By the time the atria try to dump what they have into the ventricles, simple diffusions already fill those ventricles 80%. So the ventricles, or their atria, when they do contract, they don't have to contract real strong to get that other 20% in there, and then the valves close and we're building pressure, and here we go fixing to contract the ventricles. Pressure changes during cardiac cycle. This is a cyclical thing. They're going through some steps, and I don't know that I would start and end where they do, but it still serves the same purpose. As the ventricles begin their contraction, see, to me they're starting at the middle of the whole mess, but as they begin their contraction, the intraventricular pressure rises. As we know, it's got to rise above that of arterial pressure to get it out there, causing the AV valves to snap shut. That's so we don't go back to the atria. At this time, the ventricles are neither being filled with blood nor ejecting blood. They're building pressure. They're trying to overcome outside pressure. And the intraventricular pressure has not risen sufficiently to open the semilunar valves. This is the phase of isovolumetric contraction. So the ventricles are full, we're building pressure. Number two, when the pressure in the left ventricle becomes greater than pressure in the aorta, the phase of ejection begins. Semilunar valves open. The pressure in the left ventricle and aorta rises to about 120, which is our upper end on our systolic, right? When ejection begins and ventricular volume decreases. Number three, as the pressure in the ventricles fall below pressure in the arteries, the back pressure causes semilunar valves to snap shut and produce the second heart sound. The pressure in the aorta falls to 80 millimeters of mercury, while pressure in the left ventricle falls to 0. During the isovolumetric relaxation, the AV and semilunar valves are closed. The phase lasts until the pressure in the ventricles fall below pressure in the aorta. You know, at that point right there is where the heart actually gets its blood supply. If you think about that, we've built enough pressure, we've ejected the blood out through the aortic semilunar valve. Now pressure in the ventricle has dropped to 0. Pressure out in the aorta and arteries are 100 plus. Where do you think blood's wanting to go here? Back or forward? Where's the least pressure? Back. So they want to turn and go back to the ventricle because its pressure is 0 now. But the semilunar valve snaps shut, will not let it go back, but just outside the semilunar valve is the coronary artery. The whole heart is relaxed now, right? Atria's already contracted, ventricle's just contracted, everything's relaxed. And so blood rushes in the coronary artery and feeds the heart tissue during this 0.5 seconds of relaxation. And so if I ask a test question about it, when are the coronary arteries fed, or when is the heart fed with blood? It's during ventricular diastole. Ventricular diastole is when the heart is fed. And notice this is fresh oxygenated blood. I mean, it just came from the lungs just a little bit ago. Went through the left side, pumped out, come back, fed the heart, and then moved on. The heart gets first choice. So ventricular diastole. Then number 4, when the pressure of the ventricles fall below the pressure in the atria, the AV valves open and we start rapid filling, which is simple diffusion. Then number 5, atrial contraction or systole delivers the final amount of blood, which is about 20%, it's not a whole lot, into those ventricles. And then we'll start right back to the first one. We talked about the SA node and the AV node. We know SA node's pacemaker, but we decided if it quit, the AV would take over at 50 beats a minute as an ectopic pacemaker. But if the AV ever quits, we're in trouble because there's 70 coming in and 30 going out. That's where the bundle of His picks up. And they list all that on 422. On 423, under excitation, contraction, coupling, and heart muscle. I'm not going to go into this in a lot of depth, but I want to point out what cation or what element on that periodic table is important for muscle contraction. Look in that, just look in that paragraph. Yeah, calcium. Calcium is listed in that paragraph 24 times. Now, if you can't get it out of that, you're just a little slower than what this class needs, okay? And that's not for just the heart. That's for every muscle in the body. Calcium is a necessity for muscle contraction. I mean, we learned from the parathyroid gland being removed accidentally and the dog's dying and that little dab of research is doing, that quickly if calcium is diminished, death occurs. So, clinical application, digitalis. Digitalis binds to and inactivates the sodium-potassium ATPase pumps in the plasma membrane, thus reducing the ability of these pumps to extrude sodium. So if you don't take out sodium, it stays in there, producing a rise in cytoplasmic sodium concentration, which reduces the sodium concentration between the inside and out, so that the diffusion of sodium into the cells is decreased. The decreased diffusion of sodium in the cells then reduces the ability of sodium-calcium exchangers to extrude calcium. So we're maintaining calcium levels, which maintains a stronger heartbeat. Digitalis maintains a stronger heartbeat. So that's ultimately what that does. It says it increases the amount of calcium in the sarcoplasmic reticulum, thus that is responsible for the increased strength of myocardial contraction when a person takes digitalis. So we're making that old heart stay strong with that particular drug. How long will that be maintained? Those old hearts we're working with, who knows? Because some of them's got a lot of miles on them. On 424 electrocardiogram, this is the P, QRS, and T wave, and I do have test questions about these on the test. The spread of atrial depolarization is the P wave. Atrial depolarization. So that's the atria contracting. The QRS is depolarization of the ventricles. That's the ventricles contracting. And the T wave is repolarization of the ventricles. Repolarization of the ventricles. So P, QRS, and T. Now, as far as correlation, this is where it answered the question on the lab right here. Depolarization of the ventricles, as indicated in QRS wave, stimulates contraction by promoting the uptake of calcium into the region of the sarcomeres. So the QRS wave is thus seen at the beginning of systole. This rise in intraventricular pressure that results causes AV valves to close so that the first heart sound, S or lub, is produced immediately after the QRS. Immediately after the QRS. Repolarization of the ventricles indicated by the T wave occurs at the same time the ventricles relax at the beginning of a diastole. Resulting fall in intraventricular pressure causes aortic and similar valves to close, Thus, the second heart sound, dub, is produced. So it correlates shortly after the T-wave. Then we have artery and vein comparison. Our main comparisons are arteries are resistance vessels, veins are capacitance vessels, arteries are thicker, they have elastic recoil, veins are thinner, they stretch but they don't recoil, they have one-way valves. There's your primary differences. And at any given time, most of your blood's found in the veins at any given time because they do pool. There's capillaries. They say there's 40 billion capillaries in the body. 1,000 square miles of exchange. That's a lot of mileage. A lot of resistance there, but not as much resistance as the arterioles. We just slow things down so we can get it to exchange. Different types of capillaries. We have continuous capillaries. Those found in muscles, lungs, adipose, and central nervous system, where the endothelial cells are closely joined together. Those are continuous. Fenestrated capillaries occur in the kidneys, endocrine glands, intestine. They're characterized by wide intercellular pores. And discontinuous is kind of a dead end. Liver, spleen, bone marrow. These are all places where either red blood cells start and enter the system, or red blood cells end and die. So discontinuous. All right, we've covered veins. What did we say our number one means of venous return is, since we don't have much pressure? Oh, Josh is thinking hard. He's already clicked his brain on vacation. Number one means of venous return. We have 2 millimeters of mercury in the veins. We have 100 millimeters of mercury in the arteries. We don't have a lot of pressure, so we've got to get it back to the heart somehow. It is muscle contraction. You move, blood moves. You don't move, blood doesn't move very much at all. It becomes pool. So, muscle contraction. They list a couple other things. One of those would actually be breathing mechanism, which does involve muscle contraction, but through the breathing mechanism you have a thoracic cavity that when it expands, atmospheric pressure drops pretty low, so air can rush in. Well, that expansion is less pressure than what's there, and blood tends to flow up to that less pressure area. Other than that, there's one, I saw one book say something about atrial suction. There's not a lot of suction when the atria is 0 and the pressure in the ventricle or in the veins are 2. We don't hear any sucking sounds here, that's for sure, but it's going to go from higher pressure to lesser pressure. In this case, it's going to crawl there unless muscles are contracting. But breathing is good though. That's muscle contraction. So if you're not breathing, your blood's not going to circulate. That's a pretty good one to remember there, Josh. Atherosclerosis. Most common form of atherosclerosis, and through the contribution to heart disease and strokes, responsible for about 50% of deaths in the U.S., Europe, and Japan. Then we get plaques or arthromas. Arthromas additionally serve as sites for a thrombus, which is a blood clot. What happens if that, what is it called if that blood clot breaks loose and travels? Anybody know that terminology? It is a ticking time bomb. Depends on where it wants to lodge, but it's an embolus. Yep, it's an embolus. And if it does cause the ticking time bomb, then that'd be an embolism. Yeah. So things that, of course, encourage this kind of stuff is hypertension. If you have hypertension in your family, I highly encourage you to keep up with your own blood pressure, because hypertension over time will harden arteries because they're trying to hold that pressure. So they maintain a sympathetic tone, which stiffens them and does not allow the elasticity those vessels should have. And over time, they just become stiff and hard. So we need to maintain the elasticity of those vessels, because even with age, we're still going to lose some of that. Smoking, that's always a given thrown in there. Curly's quit smoking because of this class. Maybe you started drinking because of class, but she quit smoking. That's good news. And I like the way they put this. All these things insult the system. So when you smoke and drink and maintain high blood pressure and the lifestyle that encourages the bad things, then you're insulting the system. How dare you insult the system? So I like their terminology there. Moving over to cholesterol and plasma lipoproteins. Well, we know the good, bad, and ugly, right? What's good? Well, I just thought you knew the good, bad, and ugly. HDL's good. LDL's bad. What's ugly? VLDL. VL, very low density lipids, is ugly. That stuff's ugly. Y'all's comprehension time, ability over time is not real good, is it? We need to work on that long-term potentiation. I think in the future, I'll just have a class, I'll just pick topics in each chapter and have the class do presentations, and you'll do your own lecture and learning, and I'll just sit back and don't have to do squat. That's where education's going. We gotta be smarter than y'all and quit working so hard. Let's see, inflammation and atherosclerosis. Well, atherosclerosis is now believed to be an inflammatory disease to a significant degree. Inflammatory disease. If that's the case, we can take anti-inflammatories throughout the rest of our life if those don't kill us, and that would actually help the problem, would it not? The evidence of measuring this is through a C-reactive protein, a marker of inflammation. It's better evidence than low-density lipids. That's what they've been going by, but it's not a direct correlation. Low-density lipids is not, but C-reactive proteins are. That shows actual inflammation. On 434, fitness application, it's just basically talking about significant ways to lower your cholesterol in everyday life. And it's talking about lifestyle. I mean, we all get into certain habits. Hopefully they're better habits than not. But we get into certain types of foods we like, and we know they're not good for us, but we got to have them every now and then because we're addicted to whatever it may be. Me, I'm a beans and tater kind of guy, so that's not real good for cholesterol. So I try not to eat them as often as I would like to eat them, but I'm sure not going to turn them down if they're put in front of me. So that's what this is talking about, significantly lower blood cholesterol concentration through a regimen of exercise. Exercise will always play a role in that, and exercise will actually lower your appetite because you're not hungry if you just got finished exercising, and so that helps your diet consumption. So if you're bad at consuming the bad things, you won't consume as much of it if you're exercising. So that's a double-edged good sword, if you will. Other things, saturated fats in diet raises blood cholesterol, such food as fatty meat, egg yolk, internal animal organs. Backing off the old liver and things like that our parents used to make us eat. Liver and onions was a delicatessen in their days. And most disgusting thing you ever lap your lips around. Do you like it? Never had it. You're not missing anything. And here was their reasoning back then. Liver was high in iron because it was a main component that broke down red blood cells. So when you cook liver and onions, you were supplying iron back in the system.
Isn't it also high in toxins?
Yeah, it's your detox center. So can you imagine eating chicken liver after what they have to, because for a long time they put, wasn't strychnine, it was, what's another rat poison out there besides strychnine? It was a type of poison. They actually added it to the chicken feed in very, very small amounts, and what it did is kept the intestines irritated enough that the chicken would consume more food and gain weight faster. But what organ had to deal with that? The liver. So literally when you ate chicken liver that had been fed that feed, you were consuming toxins. Just like a bad wife poisoned you over time. Maybe she chucked you a lot of chicken liver, huh? You gotta watch that. But they're talking about, back to egg yolks, they list egg yolks. Well, at one time, they just literally, eggs are gonna kill you. They're just terrible. They're not near as bad as they once said they were. There's a lot of good components in eggs. In fact, the good components of eggs far outweigh the bad components of eggs. It's just a realistic situation. You don't want to sit down and eat a dozen eggs a day kind of deal. But there's a ton of good things in eggs. So don't let that scare you away. I can tell you stories and stories over eggs, but American Heart Association recommends that fat should contribute less than 30% of total calories of the diet. In today's fast food restaurants, I would estimate we're probably upper 60 to 70% of your diet is fat consumption, and that is not good. We're supposed to be at 30%. All you can do is actually go by and sniff McDonald's to keep it at 30%. If you actually stop, you're going to get 40%. So, comparison, 40% to 50% of the calories in fast food meals derive from fat. In addition to one meal of oily fish, such as salmon, sardines, mackerel, and swordfish. You like any of those? You a sardine girl? We dissected sharks up there in lab the other day in zoology, and that's what they smell like. When we pull them out, they smell like sardines. And somebody said, I'll never eat a sardine. That's what it smelled. It didn't smell pleasant, but it's kind of one of those things that grow on you. Mackerel, I like mackerel. I've eaten swordfish. Salmon is a little strong, but knowing it's good for me, I'll choke some more of it down. I'll take a salmon patty, a boneless salmon patty, and grill it, and use a solution of brown sugar and soy sauce and some smoke in that, and let it cook the juices out. And it's actually pretty good, but it's a really strong fish, but it's the strength in it is what's good for you. Sardines, it'll be a hungry day when I eat those. But eating that, it says once a week or so, can significantly reduce risk of myocardial infarction. Now, there's a lot of people out there that don't like any of those. So what do instead? What can you go to the drugstore and get that would suffice for eating this fish?
The fish oil pills.
Those fish oil pills. Omega-3s. There's a ton of them. The best one out there now is, I want to say shrill, but it's krill. Krill oil supposedly is the best one out there.
Does flaxseed have it in there also?
Flaxseed will help. Yes, it will. Flaxseed in clinical trials will definitely lessen horribly bad cholesterol. They like I said, I could tell you stories that go back to chicken trials and eggs where they actually fed chickens flax, and they fed the chickens flaxseed in the chicken feed, and they saw bad cholesterol in the eggs go to good cholesterol. Because what was happening is the chicken was eating flaxseed, converting bad cholesterol to good cholesterol, and it was overspilling to the eggs. So now we had eggs with HDL instead of LDL in them. So these were positive things. Well, then in all theory, if we take the flaxseed, it'll do the same for us. I take a flax oil seed pill every day myself. But before that, I was taking omega fish, whatever, caught on sale at Walgreens. It's just one of those. But I do take that every day. That helps me feel better about counteracting fried potatoes and Big Macs. So, for reasons not completely understood, N3 fatty acids exert a protective effect on the heart. The single most effective action that smokers can take to lower risk of atherosclerosis is stop smoking, just like Curly did. Well, there's a no-brainer, huh? Feel better, don't you, Curly, since you quit smoking? Got more oxygen flow and energy, and no comment as usual from Curly. Well, all this stuff leads into ischemic heart disease. What do they mean when they say ischemic? Lack of oxygen. Lack of oxygen is going to lead to pain. When a muscle doesn't get oxygen, it's going to gripe at you, and that's what it's going to do. Ischemic heart disease is leading into angina pectoris, which can lead, won't always, but can lead to myocardial infarction. If part of your heart doesn't have enough oxygen and it quits, you're going to feel pain. And you have deferred pain. It'll run down your left arm, left leg, sometimes upset stomach, tightness in the chest. There's a ton of things that go along with that. And how we can determine if you've had a heart attack or not is by some enzyme tests that they can do. Plasma concentrations of creatinine phosphokinase increase within 3 to 6 hours after the onset of symptoms and return to normal after 3 days. So from 6 hours after onset of symptoms up to 72 hours, we can test for that. We find it in your blood, we know you've had a heart attack. And sometimes it's a week before we drag somebody in there that we've known that's had a partial heart attack or they had some serious chest problems going on. And then we can test lactate dehydrogenase, reaches a peak 48 to 72 and may last up to 11 days. So they'll run tests on those, and if we have signs of those in there, then we can see what kind of damage has happened to the heart and possibly prevent the next one, which may be lethal. So we've come a long ways in heart protection, which is very essential for sure. Stroke, boy, there's a lot to say about that in that clinical application, simply because it's probably one of the worst, most debilitating situations you can get yourself in. And people have pin strokes all the time and may not even know it. But a massive stroke can go from killing you to just basically maiming you to the extent you're non-functional. I mean, it can reach that point. Fortunately, we are good enough in therapy, which a lot of y'all's going into forms of physical therapy, radiology. Well, in physical therapy, they have ways of retraining muscles and using different parts of the brain to do what other parts did. And speech therapy retrains for speech and communication, and occupational therapy does other things, and it mixes in there with hands and occupation and eye coordination. It works with physical. It's amazing what we can do with time. But here's the kicker: if the patient is willing. If there is no willingness in that patient, you're just spinning your wheels. They've got to have the want to. And you'll find that very frustrating in that field of medicine. Who's in that program? Is anybody in it? You going into it? You can ask any physical therapy instructor over there if that's not one of the most frustrating components of what they do, is having somebody willing to do it. And there'll be days that show up and they're willing. There'll be days that show up and say, I just don't feel like today, I'm not going to do anything. And they won't do anything. So, arrhythmias detected by electrocardiograph, bradycardia, tachycardia. Talk about athletes' bradycardia. We talked about lowered heart rate due to strength of the heart with trained athletes the other day. And it can actually reach a point that holds the SA node down to about 50 beats a minute in that deal, and that's too low. We're not getting enough done with that, and that is definitely athletic bradycardia. They talk about the ectopic pacemakers. Anything outside the SA running this show is ectopic. Says that the abnormal atrial tachycardia differs from normal sinus tachycardia. Ventricular tachycardia results in abnormally fast ectopic pacemakers, and the ventricles cause them to beat rapidly and independently of the atria. This is very dangerous because it can quickly degenerate into a lethal condition known as ventricular fibrillation. So that's kind of where we're at on the next page is fibrillation. Man, didn't quite get done. You have flutter, fibrillation. We'll just start there, I guess, when we come back after the break on Monday. I wanted to finish it for the film, but I didn't get it done. But it won't take long to finish this. We'll talk about our different degree node blocks, and we'll finish this chapter, and we'll be in the Physiology Chapter, which is chapter 14. Do our best. Get her done.